Welcome, everyone. I'd like to thank all of you for attending the Society of Skeletal Radiology Resident Education Club webinar. This month, we're going to be covering orthopedic trauma cases for call and beyond. I'm Jonathan Flug. I'm a musculoskeletal radiologist at the Mayo Clinic in Arizona, and I'll be your moderator for the session today. And it's my honor and pleasure to introduce Dr. Joseph Delic, who's going to be the speaker today. Dr. Delic is an assistant professor of radiology at the Allegheny Health Network and serves as the musculoskeletal radiology fellowship director there. He completed his residency at the University of Pittsburgh and a fellowship in musculoskeletal radiology at the University of Wisconsin. He just wrapped up a term on the SSR's Resident and Fellow Education Committee and is a recent recipient of his radiology residency's Excellence in Teaching Award. So I have no doubt this is going to be an engaging and interesting review tonight. So with that, I'd like to turn it over to Dr. Delic.
All right, Jonathan. Hey, thank you very much. So yeah, really excited to be here. Wanted to thank the SSR and the Resident Fellow Education Committee for inviting me. Like I said, I was on the committee for a couple of years. I'm really enjoy teaching. I really enjoy working with my residents and some of the residents through the SSR. So hopefully this will be a good evening for everybody. So I work in Pittsburgh at the Allegheny Health Network. We're a very large tertiary care center. We have a large volume of trauma cases that we see, but we also get to do some fun stuff like we do imaging for the Pittsburgh Pirates as well as a number of the other local sports teams. So we get to see a lot there, which is great. So let's go into our goals here this evening. There we go. So what do we want to talk about? Well, I want to review some common trauma cases. And specifically, I want to focus on what are some cases that are similar, and then what are the differences between them that can help us, determine what the diagnosis is. And when I work with my residents, I really like to go through as many cases as possible. So the way I structure this lecture is we're going to go through things pretty quickly. We're going to use the poll everywhere system, but we're only going to go for maybe 15 seconds or so for our answers, and we're going to move very quickly to the next case. And so, what I want you to do is just take a look at the case, do your best to answer the question, and then we're going to kind of move on and get some teaching points about those cases. I was talking to my residents this week, and I remember when we did this physics review course, and they put up a question, and I'm like, oh yeah, easy, it's B, right? And then the answer comes up, and it's like 99% C, 1% B, and I'm looking around like, yeah, who answered B? Come on, so don't worry about it. Our goal today is to learn something new, and that's, hopefully we can come out of that with this. So no disclosures that I have. Anything that I use tonight is just things that I enjoy utilizing to teach my residents and things that I find helpful for teaching. So let's get going. Let's start with the first case here. So number 1A, what is the mechanism of primary mechanism of injury here? All right, good. So we have a consensus on that one. How about 1B? What is the primary mechanism of injury for this case? All right, good. So we have another kind of dominant answer for that one. So 1A is flexion and compression, right? So this is a flexion teardrop fracture. You can see here we have a fragment on this sagittal image, and then we have a fracture line going here through the axial. 1B is hyperextension. This is an extension teardrop injury. You can see this little fracture fragment here from the C2 vertebral body, but our facets are normal in alignment. So when we think about these two types of injuries, what can distinguish between the two of them? Well, for flexion teardrop, a lot of times you have a larger kind of triangular fragment of the vertebral body. A big thing is posterior displacement or retropulsion of the vertebral body, right? We're worried about that compressing the spinal cord. And then a lot of times you can get facet or interspinous widening where you get this injury with that flexion and compression type of injury. So we know that this can indicate extensive underlying ligamentous injury, spinal instability, and that spinal cord injury is really common. If we see our MRI here, right, here's our example of our flexion teardrop with that retropulsion. pinching the cord and you have that cord edema. All right. In contrast to that one, we have our extension teardrop. These are often small fragments kind of from the anterior inferior vertebral bodies that are anterior longitudinal ligament avulsions. Usually sudden hyperextension injuries cause that. They are usually in the upper cervical spine, but not exclusively. And the interesting thing about these is they can also cause the central cord syndrome due to that ligamentum flavum buckling when you get that hyperextension injury. So flexion and extension teardrop. All right, case two. What type of injury are we looking at here? All right, thankfully we got some brave people coming through here. Okay, we have a split between a little bit B and C. So what are we seeing on this slide? Well, we see a small ossific fragment here from the medial aspect of that left occipital condyle. All right, and this is a type 3 occipital condyle fracture. So this is something that I talk about a lot with our residents. We see it a lot in missed case conference. The point I like to make to them is when you're looking on your coronals of your CT spines, if you don't look here in the medial occipital condyle, you're not going to see this fracture, okay? This is an alar ligament avulsion. So if you look at this classification system, this is the alar ligament that attaches here to that occipital condyle. And this can be potentially unstable. So it's an important fracture that we identify. All right, next case. Where is the abnormality? I like these because you have, the brave people coming through. All right. So somebody marked back here, this metallic object that's going to be external to the patient. We have a lot of clustered here in that upper cervical spine. Okay, and so what are we seeing here? Well, if we look here, we have some anterolisthesis of C2 on C3. And if you look really closely, there's some lucency right here through that C2 pedicles. And if we look on our CT images, you can see that fracture through the bilateral C2 pedicles. And one of the important findings here is on this side on the right, you can see that extension into the transverse foramen. So this is a C2 pedicle fracture or a Hangman's type fracture. So this is actually a misnomer. The people that would undergo hanging didn't often get these type of fractures, but this is a hyperextension and distraction injury. So the important key here is to identify the fracture number one, but to evaluate for that extension through the transverse foramen for potential injury to the vertebral artery. Good. So next case, number 4, fill in the blank. What fractures are present and type if you are so inclined? Okay, I like these. So we got a lot of Jeffersons, we got Dens. I see a 2 in there, right? So those are all great. We got a Jeffy in there. I like that too. So looking at this nice word cloud, I agree with you guys. So if we look at our answers here, we have a comminuted fracture of C1, Jefferson fracture. We have multiple fractures through that ring. And if you look at our dens, you can see this fracture through the base of the dens on both our sagittal and coronal. And these are C1, Jefferson, and type 2 dens fractures. So if we review our odontoid fracture classification, we remember that type 1 is a small avulsion from the tip. Type 2 is that fracture through the base of the dens, and type 3 is the fracture that also involves the body of the dens. So 2 is the most important one, right? It can be potentially unstable and has a high risk of non-union. So that's the one that we really want to pay attention to. Again, 2 checkpoints for your coronal CTs. Medial occipital condyle for our avulsion fractures, type 3, and the dens, very important. All right, next case, number 5. Where is the abnormality? All right, so we have a big cluster down here in the mid-thoracic, mid-cervical spine, a few scattered up here, but I like this cluster down here, right? So this is a dish type fracture. And what we're seeing here is we see some asymmetric widening, both of that ossification in the front as well as the disc space here at C5-6. So there are some breaks in this upper area of the kind of ossific bridging, but this widening, this asymmetry is the key. So when we look on the MRI of this examination, you can see this fluid signal basically disrupting the anterior longitudinal ligament, extending through that anterior ossification and into the disc space. And so this is a C5-6 dish type fracture. So the keys for these is, these can involve the vertebral body, the anterior ossification, the disc space, multiple of the above. And a lot of times you can get concomitant injury to the anterior longitudinal ligament. So asymmetry is the thing that I use to help me, both of the disc space as well as the kind of anterior ossification. Comparisons are also helpful, right? Look at the old one compared to the new one. So if we look at a few other examples, okay, here's another dish fracture, essentially extending through that anterior ossification, the disc space, and going through the vertebral body, kind of even up here. You can see that a little bit better on these other slices. This is a bone and disc type injury. Here's one that's just disc. You can see that kind of asymmetric widening of the anterior disc space in the MRI, showing that fluid kind of extending between the vertebral body and the disc. One common thing that often comes up whenever I'm reading out with the residents is dish versus ankylosing spondylitis. So, how can you tell the difference, right? They're both very rigid spines. Okay, they're both very prone to fracture. But if we think about the definitions from one to the other, dish is needs to involve at least 4 vertebral levels, okay, so contiguous levels of bridging. It's often a skipping or segmental type process. This one has some pretty extensive bridging, but it doesn't involve the lumbar spine, versus ankylosing spondylitis. The keys here are this is a inferior to superior progressing disease with the SI joints often involved first. So no bridging here, you get bridging here and then works its way up from an inferior to superior. It's important with both to identify the fracture, but those are some things to help differentiate the two. All right, case number 6. Here's some quick images for you guys, and you're going to be using these to pick out where is the abnormality. Okay, I like to tell my residents when you're, taking cases in the conference, right, you have to play the game. They're showing you a soft tissue window, so there's a good chance that there's a soft tissue finding. And I like this cluster here in the back of the cervical spine. This is an epidural hematoma. So we can see this globular hyperdensity in the posterior aspect of the cervical spine. And on this axial view, this kind of globular hyperdensity there. On our MRI correlate, you can see those same findings of that globular hyperintensity. And this is again epidural hematoma. So when I'm going through my search pattern, I always look down the canal. We know that CT is not as sensitive as MRI, but you can see many things. And so on all my trauma cases, I'm always looking for epidural hematoma in the canal. I'm always looking for, is there a mass? Okay, and this is something that can be identified, especially when you're looking for it. So this is probably the only one I've seen in my career, but it's something that you can pick up. So that's a good thing to look at. Add that to your search pattern. All right, next case, right? Lumbar spine trauma. Here's a quick 3 slices going from one side to the other through the lumbar spine. And our question here is, what is the fracture type? All right, so some patients come in with these high energy trauma. They can get this type of fracture. Okay, and so I like choice B here. This is a chance fracture. So if we look at what are we seeing, we see this transverse fracture line through the vertebral body. And again, this is basically one side of the posterior elements, this the midline, and the other side of the posterior elements. And you see that fracture going all the way through, that fracture with some height loss, a fragment going to the posterior cortex, and through the other side of the vertebral body and posterior elements. That's a chance fracture. So an important thing to know about our spine injuries are the columns. So the anterior, 2/3 of the vertebral body, anterior longitudinal ligament, anterior column, middle column, posterior 1/3, posterior longitudinal ligament, and then posterior elements are the posterior column. So we know that 3 columns are classically unstable fractures, and we want to make sure we see if we involve all of these. So this is a flexion distraction injury. That's all three columns, and it's a high association with intra-abdominal injuries. So we've talked a lot about spine injuries, but like what are the most important points, right? Like I'm on call and I don't know, like, is this a chance fracture? Is this a burst fracture? Like, what am I trying to identify here? Well, I try to boil these down to a few specific things. Number one, height loss. Can you identify height loss and what is the degree? We can measure that as a percentage. Is there posterior cortex involvement with retropulsion? Okay, you can see that fragment sticking out of the back of the vertebral body. Is that narrowing the canal? Can you see posterior element involvement, right? Is there any widening of the space between the spinous processes? Or if you look very closely here, there's an associated non-displaced fracture through this spinous process. Are there adjacent levels? Okay, this is the level above, this is the level below. Some of these forces don't always go straight through like a chance fracture does. It can go through the vertebral body and out the upper or lower spinous process. So this can still be a three-column fracture, even though it's not straight through. So think of these as key checkpoints for your spine injuries. All right, so moving on from spine, thankfully, right? So we have case 8. What is our injury direction? So common thing we see, in the emergency department. One of my residents once called off because he dislocated his shoulder. I've yet to confirm if that was true or if, he just didn't want to come in that day. But I like choice A. Okay, so how about 8B? What is this injury direction? Okay, so we have a 100% on that one. Good. So we have two different injuries here, right? So if we look at case 8A, what are we seeing? Well, I agree, this is an anteroinferior dislocation. If we look on this middle image here, you can see that impaction in the humeral head, which would be our Hill-Sachs impaction fracture, and pretty subtle, but there's a few small fracture fragments here on our axillary view along that anterior glenoid, which would be our osseous Bankart injury. So I like to remember these. I'm a very simple-minded person. Hill-Sachs, humeral head, H and H, okay, those things go together. And the other one is the other one, right? The Bankart is the glenoid. So this is an anterior inferior glenohumeral joint dislocation. 8B, you can see our first image, we have this overlap of the humeral head and the glenoid with the blue arrows outlining the glenoid on our scapular Y view and the red arrow showing that our humeral head is posteriorly displaced and likely impacted on that glenoid. So the one interesting thing that I like to talk about with these is we always hear classically that posterior dislocations are related to seizures and electrocution. Well, why is that? Well, it's because when these processes happen, the muscles all tense and the patient kind of goes like this, right? Everything tenses up. The posterior muscles are stronger than the anterior muscles and have a tendency to pull those humeral heads posteriorly in that. So because of that, you can get those posterior dislocations. And again, it can be difficult to see on frontal, so it's nice to have those other views. And we have reverse Hill-Sachs and Bankart lesions relative to those. Okay, now we're going to move on now to the forearm. So we have a couple cases in a row. We had a patient that fell and has a fracture, and I want to know what's the diagnosis of this one. Okay, these are, very common terms. We see these a lot on tests. Okay, good. So we have 9A, excuse me. How about 9B? What's this one? Okay, everybody's going with B on that one. 9C. All right, so 3 similar injuries. And we've had a pretty high level of agreement on most of these. Hey, somebody had B, but they saw that everybody else was A, so they switched back. I should have took that tip in my physics review course. All right, so 9A, that's the Montagia fracture. Okay, so how do we remember these, right? Well, we're all taught the mnemonic mugger, right? MUGR, and it's supposed to indicate what is the diagnosis and what bone is fractured. So the Montasia, you have an ulnar fracture. Okay, the Galeazzi, you have a radius fracture. So then you have to remember, okay, well, what's dislocated? I like to think about it as kind of a proximal and distal. So MU, Montasia, the ulna is fractured, and proximally, the radial head is dislocated. All right. Galeazzi, the radius is fractured, and distally, the distal radial ulnar joint is dislocated. Okay, so that's how I try to remember these. The third one is the Essex Lopresti, and that's kind of its own thing. You know, the radial head and the same side, that kind of that distal radial ulnar joint is dislocated. And, you know, I try to use the first two to help me remember those. And again, the other one is the other one. Okay, so now we're going to take a look at the wrist, and we're going to have a few cases here looking at this. So this is a quick preview of case 10A. We have 3 views of the left wrist, and we're going to focus here on the lateral, this third image on the right. And I want to know, again, what is our diagnosis for this trauma case? So again, few different but similar type injuries. Okay, we have a lot of people here that's 100% choosing B. If we take a look at our similar case for this one, our companion case, 3 images here on case 10B. My residents would say, oh, Dr. Delic, there's an ulnar styloid fracture. And I would say, get out of here. That's not what I want to talk about. So we're going to again pay attention here to the third image on the right. And I want to know, what is this diagnosis for 10B? Okay, so we have a few different answers for this one. You know, certainly A, I could understand why you're thinking that. I realize that on that lateral view, that ulna looks a little bit posteriorly displaced. We want to focus here on our kind of alignment here on the lateral. So one of my favorite teaching points is we really want to focus in on this lateral view of the wrist and the hand. Okay, these alignments are very important. So when I'm looking here, I always check on my lateral view: radius, lunate, capitate, third metacarpal. Okay, this is a mandatory check on all of your lateral views. And then you want to ask yourself the question, what is happening to the lunate? Okay, this is what's helped me keep some of these straight. So if we look on our images here, radius, lunate, capitate. Okay, if we go and skip here to the middle, to the right image, the radius and the capitate are in line, but the lunate is popped out. That's the lunate dislocation. So what is happening to the lunate? The lunate is dislocated. If we go back to this second image here, the radius and the lunate are in line, but the capitate is out around the lunate. This is something around the lunate. This is a perilunate dislocation. And if your lunate is out and your capitate is out, that is a mid-carpal dislocation. So if we see here back in 10A, radius and capitate are in line, but the lunate is dislocated, that is a lunate dislocation. And B, the radius and the lunate are in line, but the capitate is out, and that is a perilunate dislocation. So remember, what is happening to the lunate? All right, case 11. So where is the abnormality here? Okay, another one, my residents, okay, they put their marker here on this chronic fifth metacarpal fracture. So please don't put it there. That's not our injury. Shout out to all my residents. You guys do a great job. All right, so I like this cluster. Okay, again, you got to play the game. We're looking at this, and there's a very subtle lucency right here through the scaphoid, and this is a non-displaced scaphoid waist fracture, right? So we know that this is an important fracture. We're going to talk about a couple other important fractures, but this is one of the key do not miss fractures in MSK radiology. I had an attending teach me the 3 do not miss fractures. We're going to talk about all 3 tonight. This is number 1. So we know these are important, right? They're risk for avascular necrosis. If you look at this diagram, again, we are taught that the blood supply works its way from a distal to proximal distribution. And when you get that fracture through the waist, that proximal pole is at risk for AVN. So if we look at the evolution of this fracture, 1 week later, there's a little bit of resorption. 3 months later, there's more resorption and no healing. And then what can that progress to? Well, a chronic scaphoid waist fracture with sclerosis of this proximal fragment, avascular necrosis. So that's a poor outcome for this case. Okay, so case 12, we have you're on call, 90-year-old female comes in with a fall to the ED. She has left hip pain. There's inability to bear weight. You get these radiographs. You're not really seeing much on this image, and the ED resident calls you and they're like, they don't know, this patient can't bear weight. And the question is, what do we need to do next? All right, what is going to be our best next step? Okay, so we have bone scan, we have CT, we have MRI. Okay, we have outpatient orthopedic and radiographic follow-up. Okay, so we have pretty close split between CT and MRI. So, we can argue what's quicker, what's more sensitive. But in our case, the next step that they ended up doing was a CT. Okay, and if we look on these CT images, we see a fracture here through the base of the greater trochanter, a little bit of step off here, and you can see this break. So, why does this matter, right? We do these radiographs, we don't see much. We do a CT, we see a greater trochanter fracture. Why does this matter? Well, the answer is intertrochanteric extension, okay? The second do not miss fracture of MSK radiology is a femoral neck fracture / intertrochanteric fracture, okay? If we look on these MRI images, this T1 and this fluid sensitive, here is our serpiginous fracture line going through that greater troch, intertroch, and even lesser troch region that we can't appreciate on the CT. So demineralization can make these non-displaced fracture lines occult. MRI is certainly the most sensitive modality. And there's rapid hip fracture MRI protocols out there where you can just do a few quick sequences and kind of get these patients in and out. That can be a way that can be utilized. But the important point is that if you have greater than or equal to 50% intertrochanteric extension, these patients have to go to surgery. Okay, so when I talk to my residents, even for those that aren't going into MSK, a lot of body imagers, okay, you're going to be reading traumas or pelvis. A key point I tell them is if you are reading plain film or CT and you see a case like this where you have this greater troch avulsion, okay, these patients need to go to MRI, okay? A lot of these patients have occult intertrochanteric extension that you just can't appreciate. So even if you're not doing MSK, you end up going into body, you see these, again, greater troch fractures, not appreciable extension on CT, still recommend the ortho consult MRI because you have to catch these intertrochanteric extension. Okay, good. So case number 13, we're going to take a look at ranking attachments around the pelvis. So ranking 1 to 7 in order, where do these tendons attach and where are these potential avulsion injuries? So you should be able to kind of move these in order from top to bottom, from rank 1 to rank 7, and it usually takes a second to update on our screen. So this is a common question you're going to see, in residency. Common question you could potentially see on a test. Good. So I like what I'm seeing on this one. We have our 1 to 7. So number 1, right, this is our abdominal musculature in the iliac crest, kind of our obliques and transversus abdominis. Number 2 is going to be the anterior superior iliac spine. That's the sartorius. 3 is the anterior inferior iliac spine, the rectus femoris. 4 is the greater troch, which is going to be gluteus minimus and medius. And then 5, iliopsoas at the lesser trochanter. 6 is our hamstrings at the ischial tuberosity, and last but not least is the symphysis pubis and the adductors. Good. So those are your avulsions around the pelvis. Next case number 14, we want to talk about pelvic trauma and pelvic lines. Okay, so this was a case I had. Somebody came in with pelvic trauma, and I'm going to zoom in here for you, and we're going to talk about on the next slide, what are the lines of the pelvis that are disrupted? Okay, so we have a obturator ring, and we see our sacrum here. So same image, just a little bit zoomed out. So you guys can fill in what lines of the pelvis are disrupted. Okay, good. I like these ones because we get to see kind of a variety of answers. Okay, so we got good, a lot of good answers. Okay, so I like iliopectineal. I like ilioischial. All right. And there's a smaller one in there, but I like that one as well. Okay. I like the arcuate lines. Okay. So if we look at the answers to this one, we can see here in our obturator ring. All right. This one is our line coming down that's disrupted right here and right here, our iliopectineal line. This one's a little bit mean, but there's a little break off here. That's an ilioischial line disruption of an inferior pubic ramus fracture. And the reason I showed this case is because of our arcuate line. So these are two cases I'm going to show you that I just had a few weeks ago. I've never seen a case of these in my time, and I finally see them. I talked to my residents about arcuate line injury. And here's our sacral fracture here and going through here. Here's our inferior pubic ramus and pubic body, superior pubic ramus fractures of iliopectineal and ilioischial lines. And these are our pelvic fractures. So we want to remember for every pelvic radiograph, the line coming down here is our iliopectineal line. We have our ilioischial line extending down along that obturator ring, ischial obturator ring here, and ischial inferior pubic ramus, excuse me. And then you can also see your acetabulum walls. But what I want to draw your attention to are these arcs, okay, in the sacrum. These are the arcuate lines of the sacral neural foramen roofs. And they're very important to look at these on all pelvic radiographs because you can catch these subtle fractures. So we want to remember that this is a ring, right? We talked about ring fractures in Jefferson. And while you don't have to memorize this Young and Burgess classification, certainly when you get fractures in one part of the ring, it could be obturator ring as the second part, or it can be sacrum as the next part of the ring. So we want to pay close attention. So if we see our companion case, again, very subtle, but if you look on the right side here, you can see these nice intact arches. But on the left, there's a step off right here. There's a step off right here. And these are arcuate fractures. And here's your CT. All right, there's the fracture right through that left sacrum into the neural foramen. So, I can't say these are common, but I've seen two of these at least that are very important that you guys pay attention. Okay, so case 15, we're going to be taking a look here and focusing on our lateral image. And then the next question we're going to be looking at is where is the abnormality? So we had a patient that fell and they come into the ED with this knee x-ray, and I want to see where the abnormality is. So there's a very important concept in MSK radiology. We talk about this a lot. We kind of have a smattering of dots here on our case, but I like where everybody's mind is at. So we have a couple astute radiologists here looking through this lateral view. And if we look at what our findings are, there's a couple things that we can see. So the first thing I want to draw your attention to, there's not much really to appreciate on this AP view, but if you look on the lateral, we see this straight line here in the suprapatellar recess, a lipohemarthrosis. And if we take a look at this tibial plateau, you can see this sharp step off right here, which is our impaction fracture. So, going through this with my residents, the first thing you need to know is what does normal look like, okay? And I made this amazing drawing with these abundance of arrows. But if we take this normal knee and we zoom in, what do we want to look at on all of our lateral views? Well, two things. Number one, if we follow this line of the blue arrows up, this is the medial tibial plateau. Medial tibial plateau is wider and often goes more posterior than the lateral, and you can usually follow it almost all the way to the front because of its anatomy. Lateral tibial plateau is usually a little bit abbreviated. It is a shorter or less wide than the lateral plateau. It has a little bit of an indent because of the fibula, and you can follow the yellow arrows all the way up here. And around this area, it's a little bit shorter AP, and that's the lateral plateau. So if we compare this to this kind of nice smooth line has very abrupt step offs. You should not see that in the normal knee. Okay. What's another important point to think about with lipohemarthrosis? Well, here's a more pronounced finding. You have this comminuted tibial plateau fracture, right? Very pronounced layering in the supratellar recess, that loosened fat versus more dependent, dense blood. And here's our CT. But how are these patients usually imaged, right? Well, if you take this image that we had and you flip it, this patients are usually imaged cross table lateral. So they're usually lying down, and that's why your layering is horizontal like this. So you see this vertical layering because that's how the image is presented to you, but this is really the way that the patient is imaged. So if we see this case of a weight bearing upright patient, look at your layering. Okay, this is a lipohemarthrosis, but it now layers horizontal because this patient is weight bearing. And if we look at our lateral tibial plateau here, here's that abrupt impaction. Again, looking here, you should not see that step off of our normal knee. So that's another impaction fracture with a layering lipohemarthrosis. And this MRI shows you that impaction deformity of the lateral tibial plateau. So lipohemarthrosis, intra-articular fracture. And again, you should not see straight lines in effusions. Effusions are usually biconvex. And we want to pay attention to our patient positioning and our tibial plateau. So every lateral view of the knee, you should be following your tibial plateaus to look for those step offs or deformities. All right, so sticking with the knee, we have a series of cases of what is avulsed. So we're going to go through 4 cases here, and I want to know what is avulsed from the knee. Okay, so we're going to take a kind of a quick trip around the knee, looking at a few different locations. All right, so a few more seconds here for this one. We have a majority of people saying E, MCL. All right, we're going to move on here to the next case. What is avulsed in case 16B? Okay, so again, I want to ask you guys the question. So, what is avulsed? Okay, so we've had some changes here. Okay, but a little bit split. Okay, very good. We're going to go to case C. What is avulsed on this one? Okay, so I'm only giving you a lateral view on this one. Taking a look for small fragments around the knee. Okay. And we have one more we're going to look at. We're going to move on here in a couple seconds here to case D. So D, what is avulsed on this one? So again, I'm just giving you a lateral view of the knee. Okay, so again, looking for those ossific fragments around the knee can be subtle in certain cases. Right. So in a couple seconds here, we're going to go through our answers to this series of cases. So moving on to 16A. So 16A is the MCL, right? So we see this small ossific fragment along the medial femoral condyle. Not very common, but possible. I think the majority of people were good with that one. If we look at 16B, though, people were more split on this one. So 16B, what is actually avulsed? Well, what is our diagnosis? Number one, 16B is a Sagan fracture. Okay. The Sagan fracture is that fracture fragment from that peripheral lateral tibial plateau. So, what does Sagan fracture have a high association with? Well, it has a high association with an ACL tear. But what's actually avulsed in the Sagan fracture? That's the lateral capsular ligament. So, there's a small ligament that attaches down there with a few other things. That is the actual piece that's avulsed. So, it's a Sagan fracture, but the lateral capsular ligament is avulsed. And here's your MRI showing your ACL injury. C is the PCL, so difficult to see much on the AP view, but on the lateral view, you see this small ossific fragment pulled off this posterior tibial plateau, and on the MRI, you can see that PCL and fragment pulled off the back of the tibia. And then finally, D is the ACL, so you can see some ossific fragments there, both in the anterior part of the tibial spines, and there's your avulsed fragment from the ACL. So nice little diagram here going through what we talked about. A few things we didn't mention. IT band comes down to the tibia at Gertie's tubercle. You have the arcuate ligament or the arcuate sign can be a little avulsion from the fibular head. And the LCL and biceps have a conjoint tendon common attachment at the lateral fibular head. All right, so 17, we're getting near the end here. Two more cases to go. Where is the abnormality here on case 17? So we're going to talk about the ankle here briefly. What are some checkpoints for looking at ankle abnormalities? And we'll touch on both the common as well as kind of the subtle places to look at. So I really like this cluster of markings here at the base of the fifth metatarsal. So this is a non-displaced fifth metatarsal fracture. So when I'm looking at my ankle radiographs and talking to my residents, I like to go through kind of two sets of checkpoints with them, right? We have three very common fractures that we see: medial malleolus, lateral malleolus, posterior malleolus of the ankle. So I always run my search pattern through those first. But where can you also see fractures that are a little bit more subtle? Well, occasionally you can get avulsion fractures from either the medial and lateral talus. So on the AP view, I take a look at those. And on my lateral view, I have a focus on that anterior process of the calcaneus, looking through the talus to see that, as well as the fifth metatarsal base. A lot of patients come in, twist their ankle, and they end up with these fifth metatarsal base fractures. And this is the only image that you see them on. So remember, medial, lateral, posterior malleoli, medial talus, lateral talus, anterior process of the calcaneus, and the fifth metatarsal base. All right. Well, I appreciate you guys sticking with me. We have one last case to go. We're looking at same patient here, two radiographs, same foot. One is non-weight bearing, one is weight bearing, and we want to discuss where is the abnormality. So we've talked about the two out of the three do not miss injuries slash fractures of MSK radiology: the scaphoid, the femoral neck slash intertroch fracture. And this is number three here. Okay. So we look at this radiograph: weight bearing, non weight bearing, right? This is a very important concept to remember. And if we look at these radiographs, what happens here? Well, on the weight bearing views, you get widening of this Liz Frank interval, right? Little step off at the second metatarsal, middle cuneiform articulation, second TMT. If you notice, this articulation looks essentially normal on this non-weight bearing view, but this is perpetuated or exaggerated by this weight bearing image. So this is a Liz Frank injury. So when I'm looking at these, this second TMT alignment is my key touch point for looking for Liz Frank. So we want to remember the Liz Frank ligament, medial cuneiform to second metatarsal base, very commonly crus injury or load onto the plantar flexed foot. And there are, main subtypes: homolateral, divergent, or isolated. And certainly we know, there are a lot of complications that are possible between non-union or just very bad arthritis if these are not diagnosed. So remember, homolateral with all of the metatarsals moving in the same direction. So 1 through 5 here, all moving laterally. And divergent, the first metatarsal moving medially with the second through fifth metatarsal moving laterally. So again, three do not miss: scaphoid, femoral neck, and Liz Frank injuries. So appreciate you guys listening. These are some references and good resources that I like. Um, Again, I really enjoy teaching. I've been a mentor for people in SSR. If you have any questions about the lecture or just in general about residency fellowship, please feel free to reach out. I'm always interested in talking. And thank you again to the SSR and everybody for attending. We'll turn it back over to Jonathan. Thank you very much. I'll
Joe,
stop.
that was fantastic. Thanks so much for that. You really hit all the high points, some real great cases, and real beautiful examples. I think there's going to be a survey link in the chat coming up where folks can give us feedback on the webinar. And I want to encourage everyone to use that, give us feedback, even if you're Dr. Delic's family or resident. We want all your feedback and any information on how we can improve.
Yeah.
While folks are doing that, Joe, I just one question I had for you. Do you have any tips or advice for maybe a standardized or structured approach to the spine when you're looking at these trauma cases? I know you mentioned a few cases where there's specific, views or recons you want to look at, and
Mhm.
if you have any tips or suggestions, for lumbar spine and thoracic spine evaluation on chest, abdomen, pelvis studies, where you may
Yeah.
find some incidental findings.
Yeah, absolutely. So, I mean, when I teach my residents and when I go through these, I ascribe to the ABCDE method, right? So, just in general, when I'm doing any spine, I'm always going to go through alignment. I'll go through bones for fracture, you know, canal, D for discs, and then E is everything else. So I always look at facets, specifically radiographs, cervical spine, prevertebral soft tissues. But when I go and kind of drill down a little bit into my CTs, again, I follow that same thing. When I'm looking at my cervical spine, I really like to kind of take a look at on my sagittals stesis, facets, craniocervical junction. Coronals, again, I mentioned I do my dens and my occipital condyles. They're very key points. And my axials are going to be transverse foramen in the cervical spine, right? Very important to make sure there's no fracture that could potentially involve the vertebral artery. And then whether it be, the T&L spine, I follow those same type of search pattern, uh, going through kind of the same A, B, C, D, E. And then certainly at the end of both of those, cervical spine is going to be canal and prevertebral soft tissues. Same with T&L spine, canal and prevertebral soft tissues. Again, looking for those epidural or maybe prevertebral hematomas that you can catch. So certainly there are many ways, but those are the things that I kind of touch on when I go through with
Excellent. Well, I think that's it for the questions, and the link is in the chat. And I do see one more question. Is there any other indication to order MRI instead of CT scan, like the intertrochanteric fracture?
yeah, I mean, and Jonathan, I don't know what you guys do. I mean, do you have any process in place that kind of helps standardize that, or is it just kind of pretty up to what the kind of the cases go through the ER?
For our intertroch fractures, it's a the ED will consult ortho first, but
Yeah,
we've worked on a fast hip protocol,
yeah,
and as soon as they see any intertroch or greater troch fracture, they're requesting a fast one of our fast pelvis MRs. And I have to say, it seems almost more likely that there is intertroch extension than there won't be.
yeah,
So we definitely don't push back at all, if they want that. And I think in that population, again, you can't discharge them and have them follow up as an outpatient. So you really have to get
yep,
that done in the ED setting.
yeah,
But there's very few other, indications that I can think of. We don't do spine in our division, so I think the indications might be spine for MR in addition to CT, but in the extremities and in the the peripheral joints, pretty rare. The Liz Frank, can be followed as an outpatient, and you certainly don't want to recommend that in the ED setting
yeah.
for an
Yeah, I
MR.
mean, I would agree. It's pretty similar, and yeah, I mean, ours is kind of a little bit variable, but I really like the idea of the rapid hip protocols if they will be implemented, and you have a good kind of, you know, tree of decision making that it can go through. That can be, it can save a lot of time and it can save money in scanning too. So, but always challenging.
Yeah. And I would say for the residents here, you may feel a little bit intimidated about having to read, a pelvis MR on call without attending backup, depending on your situation. But these fracture pelvic cases are usually pretty straightforward. Is there signal abnormality in the intertrochanteric femur or not?
Yeah.
And usually that's the extent of what you need. So. Um, oh, and I see one other question. Is the proton density useful in emergency or just T1 and T2? Talking about intertrochanteric fracture. I don't know if Joe, you want to
Yeah,
take
I
a
mean,
stem.
I would pick if I had the choice, I would pick the T1. We basically from what we've done, we usually do a chronal T1, chronal T2, fat set or stir if you can do that, and then axial do fat set or stir. Basically, getting one T1 and then a fluid sensitive sequence in there, and that can really answer your question usually pretty quickly.
And we our protocol is full pelvis because occasionally you'll see some other findings that that may warrant discussion, but certainly I don't think anyone is expecting you to talk about smaller tendinous or ligamentous structures around the hip in these cases. So well, great. Well, that's all I see. So I want to thank everyone and thank you all for hanging with us after hours today. And our next session is going to be Approach to Ankle MRI, presented by Dr. Vishal Desai from Thomas Jefferson University Hospitals, and that'll be December 11th, 7 p.m. Eastern. So hope to see you all then. And again, thanks, Joe. This was fantastic.
Yeah, thank you everybody for attending. Appreciate it. Thanks, John.